disorder involves regurgitating food that's recently been eaten into the mouth and then re-swallowing it. That can be caused by medical conditions like acid reflux, gastroparesis. We also see it in patients with other eating disorders, but I don't recall having patients here or personally where that was their sole diagnosis. And I'll go into some of these categories in more detail right now. So one of the eating disorders we do treat here is called avoidant restrictive feeding or eating disorder, abbreviated as ARFID. This was a diagnosis added in DSM-5. People were aware of its diagnosis or its existence prior to that. And for a while, 10 plus years ago, it was called selective eating disorder. It involves a significantly low body weight or some other sign of a serious nutritional deficiency. But unlike anorexia nervosa, it has a sort of different cause or function, which is that the person is either just not interested in food. More often we see people who have sensory or texture-based aversions to certain foods. So for example, foods that are crunchy or hard, or maybe foods that are mushy, the person avoids, or maybe they only eat foods that are white in color. Or they're sort of afraid of some other consequence related to eating, like choking, vomiting, their teeth falling out. So it doesn't have the sort of body image component that other eating disorders do. And often these patients, when they're underweight, recognize that that's a problem, often don't like it, often want to restore weight, but they have trouble doing so because their diet is limited to a very small, sometimes, number of foods. And unlike in some of the more thinness-oriented eating disorders, the foods that they prefer tend not to be organic quinoa and broccoli, but things like chicken fingers, mashed potatoes, macaroni and cheese, foods that would be scary to someone maybe with anorexia nervosa or something like that. Speaking of anorexia, the DSM-5 does tell us that this probably occurs in about 0.4% of the population. The sort of hallmark feature is a significantly low body weight, body image problems, and often a fear of fatness is what they call it, or weight gain, or, and this was a change in DSM-5, or at least ongoing behaviors that interfere with the need to restore weight, or a lack of awareness of the kind of seriousness of the low body weight, or at least, someone who doesn't, report having a fear of weight gain. There's two subtypes. One for people for whom the significant weight loss occurred because of dieting, fasting, exercise, the so-called restrictive behaviors. And another subtype for people who also experience binge eating in the context of anorexia, binge eating and purging, or people whose weight loss might primarily be a result of purging, which is defined as you see here. Laxative, diuretics, enemas, they're not thought to really have any actual effect on calorie absorption or retention. These behaviors are sometimes reinforcing for patients though, because they do, through like water weight loss and things of that nature, cause a drop in the number on the scale. Laxatives can sometimes give people a temporary flatter appearance of the stomach. Purging by way of vomiting, though, does rid the body of calories. There have been a couple of studies done on just how much. And they tend to suggest that it might only be about 50% effective. So getting to bulimia, many patients with bulimia will often have a normal body weight or even a higher body weight because purging by way of vomiting is not as effective as it might seem when they sort of started to go down that path. I underlined the word binge so that I would remember to explain exactly what that is or isn't. But a binge is a discrete period of time where someone eats an abnormally large amount of food for the context or setting. So just because you've eaten a large pizza before all by yourself, or just because, somebody might consume several thousand calories at Thanksgiving dinner, that's not necessarily a binge because it's sort of appropriate to the setting and also probably does not involve a loss of control over eating for the person. The main difference between bulimia and binge eating disorder is that there's also the presence of harmful or inappropriate compensatory behaviors designed to kind of undo the consequences of the binge. And those include the behaviors mentioned in the anorexia subtype involving purging, but also things like fasting, meaning that if there's a patient who maybe does not eat at all for 3 days and then has a very large binge, and that's sort of their pattern, but they're maintaining, a relatively normal body weight, they would be diagnosed with bulimia rather than anorexia binge purge subtype. There's also sort of a frequency criterion in the DSM, which is that the behaviors have to occur on average at least once a week for at least the past 3 months. I'm not aware of any particular reason for this cutoff. Many people think that it's somewhat arbitrary, whereas other disorders, there's more meaningful cutoffs between like what is a mild substance abuse disorder versus a severe one. And in the previous DSM, it was twice a week on average, and they reduced that to once weekly, I think because they felt like there maybe wasn't a big clinical difference between once or twice a week. People with bulimia, though, also typically have body image issues, and their binging and purging behaviors are related to that. And like with many disorders, there's a qualifier that it can't be better explained by another mental health or physical health disorder. Binge eating disorder was officially added to DSM-5. It, of course, also involves episodes of binge eating. We have a little bit of an expanded definition of what a binge is, though, in this context. It can involve eating rapidly, eating in spite of not being hungry, eating past the point of uncomfortable fullness. So I've heard patients talk about how they have to kind of lay down for the rest of the evening after a binge because they go too far, in their opinion, and aren't able to stop. And I think this is also true of bulimia, but it's sort of spelled out here that there tends to be significant guilt, shame, self-loathing, and other emotions related to the perceived loss of control over eating. We have the same frequency requirement, a reminder that the binge eating can't be better explained or happen in the context of something like bulimia or the anorexia subtype. This diagnosis used to be called eating disorder not otherwise specified, but in DSM-5, they do specify some options for how this might present. Atypical anorexia, which is a newer category, refers to people who meet all of the criteria for anorexia nervosa, but they do not, at least yet, have a significantly low body weight. So sometimes we will see patients who maybe started developed their eating disorder when they were at a higher weight, and despite significant rapid weight loss, severe calorie restriction, their weight is not yet at a significantly low level. There's also low frequency or limited duration bulimia or binge eating disorder, which means that the person generally meets the criteria for those disorders, but they don't meet that once a week on average for the past 3 months piece. Purging disorder you could think of as like bulimia, but without the binge eating and also without a significantly low body weight. Night eating syndrome is not something that I have too much understanding of. It's not something that we treat at McCallum Place, and my impression is that it's thought to be sort of different from some of the more recognizable eating disorders in terms of its etiology. Then finally, a diagnosis that you can give is unspecified eating disorder, not to be confused with other specified eating disorder. And this is when you feel the patient meets the general criteria for an eating disorder, but does not meet the criteria for any of the specified disorders, or you're unsure because perhaps you're meeting the patient for the first time and you're trying to evaluate for someone who is maybe purging, do they have bulimia, purging disorder, anorexia nervosa, binge eating, purging subtype? So maybe you need time to kind of sort that out. Many clinicians in the eating disorder world think of eating as kind of existing on a spectrum, where at one end there's normal, normalized, healthy eating. At the other end of the spectrum, there are eating disorders. And that as you approach eating disorders, maybe there's also a region that some people call disordered eating, kind of like a subclinical eating disorder, I suppose. And what are some indications that someone might have a disordered relationship with food? If someone is over-reliant on eating or not eating in order to regulate their emotions, in much the same way that someone might rely on self-injury to regulate their emotions, perhaps in the absence of other coping skills, that's a warning sign. If someone is having to spend a significant amount of mental energy on trying to control their eating behavior, especially if that's meant to influence their body shape or weight, I think that would be a factor. Along those lines, a very rigid approach to when, how, what to eat, or the opposite of, periods of loss of control over eating, specifically binges. Of course, impairment related to these things would be a factor. And with regards to weight fluctuations, everybody's weight fluctuates. We teach patients that every time you weigh yourself on a scale, there is up to a 5-pound fluctuation for reasons that really have nothing to do with your actual body composition, that are related more to your hydration status, where you are in relationship to your menstrual cycle, things of that nature. But generally, people who have a healthy relationship with food, their weight is relatively stable over time, at least if you measure that in terms of weeks or months. So if someone is having significant weight fluctuations, that could be cause for more exploration. I already sort of touched on guilt or shame as it relates to binge eating and bulimia, but in other eating disorders like anorexia, you will often see the same negative emotions related to feeling as though the person ate too much or ate something that is on the banned list of foods. And it's not just about eating, it's also about energy balance. So I've had patients before who said, I don't have an eating disorder. My problem isn't with food, it's with exercise. And sometimes my response was, well, exercise is not necessarily a problem as long as you are fueling for it appropriately. So I remember reading in some magazine maybe 20 years ago that Michael Phelps, when he was training for the Olympics, ate something like 10, 15,000 calories a day. So in spite of his pretty massive load of exercise, he was fueling for it appropriately. And of course, harmful compensatory behaviors would be a warning sign. I have more slides than I have time, so I think I might skip this one, but come back if people have questions about it. Descriptions of eating disorders tell us when eating behavior becomes a problem, but they don't necessarily tell us quite as much, I don't think, about what to strive for, what a normalized or healthy relationship with food looks like. So this was my sort of speculation about how we might understand that. There is an assessment for eating disorder pathology called the Eating Disorder Inventory 3. And admittedly, I read it in 2008, so there might have been some changes since then. But part of the manual did identify known risk factors for the development of eating disorders. Here are the high potency risk factors. One of which I want to highlight is restrictive dieting as opposed to just dieting. But restrictive dieting would be things like, I only eat meat and vegetables. I never eat other carbohydrates. It might look like a pretty severe calorie limit for the day, like 800 calories, for example. Adolescence, I also wanted to touch on. Most eating disorders develop in adolescence, and some people argue that they should be thought of as adolescent disorders, and that when they are seen in adults, it's probably because they failed to resolve in adolescence and continued in adulthood. Why might that be? Well, I think the typical age of onset for anorexia is around puberty. And I think that might come up in a later slide, so perhaps I'll save that for a little later. These are the more medium level risk factors. Low interoceptive awareness means a difficulty or inability knowing what you're feeling. And or being able to express it in words, and not just feeling in terms of emotions, but also physical sensations like hunger and fullness. And when you're tired, or, trouble recognizing when it's time to go to the bathroom. So something involving kind of being out of touch with those sort of internal sensations and having difficulty understanding and expressing and making use of them. So we see the word dieting again here, but without the word restrictive. Some people think of even innocent dieting, so to speak, as kind of like a potential gateway into eating disorders. Not that everyone who diets develops an eating disorder, but perhaps if we could stop younger people from dieting, especially in restrictive ways, maybe we would see less eating disorders. Dr. McCallum used to say that for someone who's susceptible for genetic, cultural, individual factors, that maybe those things are sort of like what loads the gun, was her metaphor, and the dieting maybe pulls the trigger. And I've definitely encountered patients who had no history of mental health problems, but they tried to lose some weight prior to spring break in anticipation of being in a swimsuit, and then they were unable to stop, even if they wanted to, even if they recognized it as a problem. And it almost seemed from their story as though dieting kind of flipped some sort of switch and they were unable to turn it off. These are the lower potency risk factors. With regards to sexual orientation, I think the research is kind of conflictual about this. I'm not 100% sure. I'm a clinician, not a researcher. But I did read one article that hypothesized that if you are trying to be attractive to a man, was the terminology they used, that you have a higher risk of an eating disorder. Whereas if you are trying to be attractive to women, because either you're a woman who's attracted to other women or you're a heterosexual man, that is protective to some extent. Psychobiological maturity. So again, puberty, especially for people going through female puberty, that is a time when there are significant changes in the body. I believe that body fat percentage doubles during that process. And there's also hormonal changes, brain changes going on at that time. And that is one hypothesis for why that might be a critical period for some people. Also, and if we have time, we'll get into treatment. One of the theories about anorexia in particular is that if you are an adolescent who sort of doubts your ability to be successful when you fly the nest, fly the coop, whatever that expression is about growing up and leaving home, if you don't really know who you are, are having trouble kind of becoming an individual and sort of being less dependent on people like your parents, or maybe you sort of sense that your parents are not going to be particularly tolerant of that separation process, that anorexia might be a way, not on a conscious level perhaps, of halting and reversing both literally and figuratively that separation individuation process. So another term that's used for that is maturity fears. And I think most of these are somewhat self-explanatory. Hyper concern, hypervigilance. I think what that means is sort of maybe a fearful, avoidant, perfectionistic, or anxious temperament might predispose someone to an eating disorder. So, how might eating disorders be impairing, especially in sort of an employment or academic setting? One thing I wanted to point out is that at least in our experience here over the decades, people with eating disorders are often very high functioning before they developed an eating disorder. Sometimes they're a straight A student or the captain of the track team. Sometimes they're perfectionistic and people-pleasing. And those traits can sometimes mask, at least for a while, how they're really struggling inside. And they also might be the kind of employees that employers really like. Someone who's always willing to say that they'll pick up that extra shift. So that sort of behavior can be rewarded and sort of obscuring of other problems. Eating disorders definitely cause problems with attention and concentration for several reasons. One is it's a direct effect of undernutrition, but also anytime someone is trying to control their eating with a lot of cognitive effort, they have more thoughts about food. A normal eater will think about food too, but maybe more when they're at the grocery store or trying to decide what sounds good for lunch, or, hey, it's Friday, maybe we should order pizza tonight and watch a movie. But for someone who's dieting, especially if they're dieting restrictively or have an eating disorder, the thoughts are much more preoccupying and they tend to be more morbid in their nature. So they drift more to things like, how do I stay under this calorie limit? Or if I eat this, then I can't eat this, and sort of a deprivation, strategizing type of mentality. People with disordered eating and beyond will often become withdrawn, turn inwards, and avoid social events that involve food, because a lot of them do. Food has many functions. It's not just nutrition, but it's also kind of fun to eat. And a lot of socializing is organized either around eating or drinking things that have calories. You might also see a decrease in productivity levels as the eating disorder becomes more impairing, or you might see an unusual increase in work productivity, perhaps because the person is really sort of engaging in workaholic behaviors in order to distract themselves from hunger and eating. And also maybe rigidity and inflexibility that causes interpersonal problems in the workplace. This is not true of everybody with an eating disorder. It's something that an eating disorder and things like malnutrition make worse. But some people with eating disorders seem to have a predisposing temperament of being perfectionistic, maybe a little black and white in their thinking. And so someone who's maybe high performing, but tends to get lost in the weeds, tends to have trouble being flexible in order to accommodate the bigger picture, someone who kind of insists that, no, there's a right way to do things, and I'm going to do it that way, even if it's more time consuming. Sometimes that comes up. So almost like qualities that are sort of reminiscent of obsessive compulsive personality disorder. If you're looking for ways to quickly screen patients for whether there might be an eating disorder present that needs more exploration, there's a handful of kind of widely used brief screening tools for that. I don't think I'm going to read these all out loud to you because you have the slides, but they tend to kind of address things I think we've already been talking about. To what extent is food a major emotion regulation strategy, loss of control, inappropriate compensatory behaviors, a drive for thinness, a distorted perception of one's body image. Eating in secret, we haven't really discussed so far. Binge eating almost always occurs in secret as opposed to in front of other people, but also in other eating disorders because of the shame and guilt and anxiety surrounding eating. There's often eating in isolation, and also, fears about what if other people think I'm eating too much, or what if other people are sort of wondering, if I feel fat, why I'm eating this much. So that could be another sort of motivation for furtive eating, as it's sometimes called. In terms of assessing in more detail, sort of beyond that initial screening phase, we tend to ask questions like, how much do you weigh? And how tall are you? And that gives me a sense of where's this person in relationship to their ideal body weight, which there's different formulas for calculating that. And it's certainly not an ideal measurement, no pun intended, but most people, it is unsafe physically or psychologically to be below their ideal body weight. So for example, one formula says that for someone who went through female puberty, if they're 5'2", they should probably not weigh less than 110 pounds unless there's really something kind of individualistic about them or their family history that would explain that. So that can be sort of a detection method, but also what is your lowest weight? Meaning, has this person ever been underweight? What's your highest weight? And how much of a difference is there between those numbers? How much fluctuation or kind of extreme changes in weight has the person experienced? How do you approach eating? When do you start eating in a given day? And when is generally the last time you eat? And how much eating happens between those 2 points? Are there any foods that you avoid eating? And is there any particular reason for that other than something like celiac disease, which would be a sort of, medically necessary reason to avoid certain foods? Do you ever feel like you lose control over your eating, or do you ever eat kind of past the point of comfort? And why do you think that sometimes happens? And if it does happen, do you ever feel like you need to do something in order to make up for it? And what exactly do you do? How much time do you think you spend thinking about food, eating, weight, body shape? What are those thoughts sort of like for you? Do you feel like they're ever excessive or obsessive or interfering at any point? Have you ever worked with a therapist or dietitian or doctor about these sorts of things before? And if so, what was that like? And was it helpful? Do you feel like these things that we're discussing cause you any problems that we haven't talked about yet? Or are there other people in your life who feel that way? Do you have a history of things like eating disorders in your family or other mental health problems? And then, also we ask about if there's any medical conditions that might cloud or influence this picture or might be a result of this picture or that might complicate treatment and working towards more normalized eating. With regards to when to refer, these next few slides will be a summary of the American Psychological Association's criteria or recommendations for how to select an appropriate level of care. These are not the only criteria or recommendations that exist, but it is a useful guide as a part of thinking about other factors. If you go to the APA website, you'll see this organized in a grid that's a little easier to understand. But what I've sort of done with these slides is, as we go through them, I'll sort of mention things that are different, but not re-mention things that maybe appeared on a previous slide or didn't change significantly. The highest level of care is inpatient, which we don't offer at McCallum Place. Inpatient eating disorder treatment tends to occur in hospitals or in facilities that are attached to hospitals. So someone who requires really extensive medical monitoring on at least a daily basis, if not on a more frequent basis, might need to be in an inpatient setting. Someone who needs to be in an inpatient setting because of another psychiatric disorder or because of their level of suicidality, but they also have an eating disorder, might need to be an inpatient. Someone whose body weight is particularly low may need inpatient. So at McCallum Place, I believe we don't accept patients who are below 70% of their ideal body weight. We ask that they go to an inpatient setting first to get to that point for a variety of reasons. One of which is something called refeeding syndrome, which is that if you're significantly malnourished or underweight, it is dangerous on the body to start refeeding too quickly. And things like electrolytes, fluid shifts within the body that can put stress on the heart in particular, need more medical monitoring than we can provide in a residential treatment setting. And also, if despite the fairly intensive structure of like a residential setting, if someone is not able to accept or adhere to treatment recommendations, they may need a higher level of care. Sometimes we have patients who continue to vomit even in front of other patients, even at the meal table. And if we're not able to really address that, or we think that they need one-on-one attention, that would be a cause for referral to an inpatient treatment center, because in a residential setting, I think it's kind of the industry standard for the staff to patient ratio to be more like 1:6, not one-on-one. So speaking of residential treatment, our highest level of care still needs intensive medical monitoring, but not to the same extent, and is able to cooperate with, adhere to our expectations and requirement with all of the structure and support that we provide. Still someone who probably who does need supervision at all meals and snacks, and perhaps also in the bathroom, and perhaps also at other times to prevent exercise. And, who has at least a modicum of motivation to at least explore whether they have an eating disorder and whether that's something that they want to work on recovery for. Oh, I think I might have skipped something. Sorry about that. So the next lowest level of care is called partial hospitalization, or PHP. In McCallum Place, we have a 10-hour version of that and also a 6-hour version of that. So still a lot of time in treatment on a weekly basis, but the person goes home at the end of the day, or they go to a transitional living environment where there's no staff present, or something of that nature. So in the case of 10-hour PHP, that has to be someone who we think is able to eat a nighttime snack if that's prescribed, or at least eat breakfast without our support, and who hopefully can also bring up and work through any difficulties that they're having with that. And also, another factor with thinking about PHP is, does this person at least have access and a willingness to reach out to some supportive people in their personal life? In McCallum Place, our IOP is 5 days a week for 3 hours a day. And at this point, ideally, someone is mostly self-sufficient with regards to meal plan compliance, because they're only eating 1 meal a day with us. So I could have sort of presented these slides in reverse, and that so I want to kind of address the question of, when is somebody not appropriate to work with you on an outpatient basis, or even, be referred to another outpatient therapist, and maybe also a dietitian, and maybe also a doctor, who they're just going to be kind of meeting with in once a week or even more frequent outpatient sessions. If someone's weight is below 85% of ideal, and in my experience, even if it's not at that level, it's very difficult for people to restore weight on an outpatient basis. There's a lot of time when they're not with you or me where they have to be kind of eating on their own and trying to override their anxiety, etc. Some people are able to do it. Often that requires extensive support and monitoring from people like family or spouses. And even then, the rate of weight gain expected is about 1 pound per week. Being underweight is dangerous, as I've said. There's some people who feel like it's also kind of toxic to the brain, and the way repeated episodes of psychosis can be toxic to the brain, and things like schizophrenia. So sometimes it's not safe to restore weight at an outpatient rate. In PHP, we're able to restore weight at more like 2 to 3 pounds per week, and in residential, more like 3 to 5 pounds per week. If someone doesn't recognize that they have an eating disorder, or they do, but they like it, don't want to give it up, outpatient treatment may not be successful. If someone is purging more than twice a week, that might also be an indication. I have had patients who got their labs drawn on a weekly basis, and the doctor sent it to me so that I could make sure that their electrolytes were not low. But once you start to do things like that, I think it's important to think about, am I kind of trying to replicate a higher level of care at a lower one? And would it be better and more efficient for this person to just go to a higher level of care and be stabilized and then return to me? Also, when someone is purging really frequently, if they are able to stop, they can experience rebound edema. which just exacerbates their pre-existing body image problems. And so sometimes they do need to be in a higher level of care in order to assist them through that process. Otherwise, you can sort of face a one step forward, one step backwards sort of pattern. My final slides are about psychotherapies, which research has identified as effective for treating eating disorders. And I'm happy to go through them in more detail if there's time, and if there aren't 18 minutes worth of questions that you might have at this point. You do have these slides if you'd like to read this in more detail. And also, I wrote a blog entry for the McCallum Place blogs a few months ago that sort of summarizes them, so you could also look for that. I believe the title of the blog was something like The Body Image Problem or something to that effect. So I'm happy to keep talking, but I also don't want to deprive time for any questions that people might have. So does anyone have any questions? I assume you use the chat if you do. Oh, a hand has gone up. Maybe.
Hi, that was my hand, if you can hear me.
Yes, I can.
Okay. Sorry. Thanks for presenting today, by the way. So I guess I'm thinking two things or questions. So presently, eating disorders don't fall under the anxiety disorders category in the DSM. Is that correct?
Yes.
Okay. I mean, I personally think maybe it should, because I think it ties in there. And then the other thing I'm wondering is, so in terms of treatment, I think, it can be a bit of a hard sell if they're getting positive feedback / reinforcement that they look good, or again, like to your point, they're perhaps, if it's a female, they're getting, attention from men and so forth. So I'm not sure how to cut through, that kind of stuff in terms of treatment, like what would be, your, suggestions where that's concerned.
Well, your second question, I probably could do a whole presentation just on that because
Right.
it can be difficult. But yeah, so one, I guess, potential criticism of the DSM is kind of dividing things up and maybe not looking at trans diagnostic factors that occur across different disorders. So yeah, if someone seems to have an anxiety disorder, but it's better explained by an eating disorder, then you give them an eating disorder diagnosis. And there might be some degree of arbitrariness to that. There are definitely some people who sort of approach eating disorders or think of them as kind of, especially anorexia nervosa, as kind of like maybe a form of OCD, but
Right.
instead of the kind of obsessive fear being about something like germs, it's about weight gain. There's even more similarities between body dysmorphic disorder and eating disorders. But regardless, exposure to things like foods, to mirrors, to wearing clothes that are more revealing of your body, that is typically a part of eating disorder treatment. So on the treatment side, maybe not the diagnosis side, there's definitely an overlap there. Your second question, I mean, one thing I would consider is that some people with eating disorders lack capacity in the way that a manic or psychotic person lacks the ability at that time to really understand the seriousness of their disorder. So sometimes patients that we see need to be committed or need to have a guardian, need to be essentially forced into treatment because their cognitive status is just not at the point where something like motivational interviewing is going to get through to them. And then there's, other cases where things like that do help, and especially with adults who still have capacity to make decisions. I find it helpful to not be forceful, but to kind of, have a more neutral stance and really hear their story and explore the pros and cons of what they're doing. And sometimes motivation from within does develop, but also maybe the person is kind of poised to resist if someone is challenging their autonomy. So that would be a short answer to pretty, complicated question.
Sorry, thank you for that.
Sure.
John, there are a couple questions in the chat.
Okay.
There was a question about, does intermittent fasting categorize as disordered eating, or is it just a controlled time frame for eating? There's also a question about touching on ethnicity and one about emotional abuse.
Sure. So I kind of last night was maybe wondering if the question about IF would come up, and it depends on who you ask. So I think the majority of my coworkers would say, yes, that is disordered because you are fasting for an extended period and then meeting your nutritional needs within a short period of time. I don't necessarily agree with that personally because it's one thing if you fast all day and then have a binge at night, but a binge is probably going to involve specific foods that you're trying to exclude from your diet because you're afraid they would cause weight gain or something like that. And a binge involves rapid eating. It involves a loss of control. And that's not necessarily true of people's eating periods when their fasting window has closed. And also, it doesn't necessarily cause impairment of any sort. And it doesn't necessarily, organize around an obsessive and anxiety-driven drive for thinness for people. So in my personal opinion, I think it depends. And then ethnicity, when I have looked at literature about that, it is also conflictual, with some people saying that your ethnicity may be because of the culture that could occur within the culture's attitudes about thinness and weight might increase your risk level or buffer you against it. But then I've also, it is also kind of a myth that, well, not kind of, it's also a myth that eating disorders are like a wealthy white female disease. So I am not sure. Emotional abuse. I think there's many sort of mechanisms for how that could be a pathway, but one would be that, a history of emotional abuse, other adversity might have interfered with someone's ability to develop healthy coping skills, other ways of regulating emotion, and probably things kind of, eating disorders often give people a sense of control. For people who don't really have a sense of identity, they can sort of organize kind of a pseudo identity around, this is the one thing I'm good at. I've always been known as the thin person. So I just think, abuse increases the risk of all sorts of mental health problems. And so I think here it's in kind of specific and also non-specific ways, probably. Looks like Mr. Teeger has a question.
Hi, thank you, John. Can you hear me okay?
Yes.
Thank you so very much. I am not a clinician. I don't really know a lot about the subject, but I've learned a lot today. I wonder if you could weigh in on what could be sort of a potentially controversial question, and I'm not raising it for that purpose. But I am confused, as many people might be, about the kind of tension between normalizing what has thought to been unhealthy behavior, specifically obesity, versus the positive aspects of not body shaming people and helping people feel good about themselves. But my own cynical view is that commercial enterprises have really encouraged a lot of unhealthy behavior because there's so many people overweight that they've decided that they can make a lot more money by upsizing all kinds of products. And so I wonder where you fit in on that. Do you think that clearly, I think we've learned that, you know, obesity is not just a matter of self-control. I think that's kind of clear, right? Which is a very good thing. But do you have an opinion, or have you had any thoughts about how we may be normalizing unhealthy behavior for other purposes, if that makes any sense?
It does. And yes, it is a very controversial subject right now in the, broader society, but also in the eating disorder world. So I'm not going to offer a single opinion, but kind of summarize the various opinions out there because I don't really know for sure myself yet. One thing that we do know is that there's some kind of registry that people can sign up for if they have lost a significant amount of weight, and I forget if that's 20 or 30 or more pounds, and they've maintained it for 2 years or more. And so far, the statistics are that only 2% of people are able to do that. So we kind of know that dieting, at least in the traditional sense, doesn't work for the vast majority of people. So I know one perspective from like one of the doctors here is, how can we tell an obese patient that they need to lose weight for their health if we have no treatments for that are really effective and sustainable? And those 2% of people who do maintain that kind of weight loss long-term, 2 or more years, when they say how they do that, they tend to do things that we might consider disordered: counting calories, logging their food on a daily basis, sticking to a calorie limit, weighing themselves daily, exercising for 2 hours a day. And again, I'm not saying that if you do that, you're a disordered eater, but there's some overlap there. There is something kind of in the field called the health at every size movement, which is interpreted, I think, a little differently by different people. But one of its, some of its points are that people should really maybe be focused on their health. And if they adopt health promoting behaviors and that results in weight loss, fine. But often what happens is that if people don't lose weight, or they don't lose the type of weight that they're expecting to, they abandon the health promoting behaviors. Part of that movement too is that health is much more complicated than just weight, and that weight should not be the first or the main metric that we kind of think about when we think about physical health. Some people who ascribe to that philosophy also argue that there are no health consequences associated with obesity, and other people say that they don't agree with that. So, like I said, that is a topic that is very much not settled as far as I can tell. And there are some people who see it as an overreaction to trying to reduce weight, stigma, and shaming. So I don't know.
Thank you, John.
Mm-hmm. We have like, I guess, about 3 or some minutes left. I'm happy to stay a little bit longer if anyone wants me to.
John, Karen asked about counting calories. Is that considered disordered eating?
Again, I think that's like, if I drink, even if I drink to the point of intoxication, am I an alcoholic or do I have a substance abuse disorder? It's a spectrum and it's not immediately clear just from a single behavior. Again, what I would think about is why is the person doing this? What is the calorie limit? How much time and energy is spent trying to maintain or adhere to that calorie limit? How does the person feel about themselves if they're not able to adhere to it? So just like television or video games or alcohol, there's some things that in and of themselves they're not necessarily problematic. There's room for like recreational use perhaps. You have to sort of look at kind of, is it causing a problem and to what degree is it taking over someone's life and interfering with other things? Now, this wasn't really the question, but a different question is trying to stick to a calorie limit an effective way to lose weight and maintain it long term. It wouldn't appear so for at least 98% of people. But just because something isn't effective doesn't necessarily mean it's disordered. I'm looking at the chat. Am I saying that any weight loss programs are considered disordered eating? No, probably for kind of the reasons I was just saying. Whether or not they're effective long-term or not is a different question. Just skimming the chat. Yeah, so there's another comment about intermittent fasting. Yeah, some people are not really doing that to try to lose weight. They're doing it because of, maybe it improves insulin sensitivity. Maybe it could be helpful with conditions like type 2 diabetes. That's something that's being discussed. And I'm not a physician, so I don't want to speculate too much about whether that is true or not to one extent.
John, can you weigh in on Noom? Do you have an opinion about that?
I haven't used it. I don't know a ton about it. My understanding is that it is kind of this, self-help CBT based and maybe mindfulness based approach to eating that also involves coaching. There's a plethora of programs like that nowadays for all sorts of things. There's apps like Noom that are designed to help people address their drinking, of course, with the disclaimer, this is not intended for people with a substance use disorder. So you have to wonder, well, who are all these people who are wanting to use an app like that if they don't have some kind of struggle with alcohol? But yeah, I mean, I don't know. I'm certainly not going to suggest that it's harmful. Again, I'm curious what the long-term effectiveness or adherence rate will be. Thoughts about new drugs available for obesity treatment? Well, don't know a ton about that. I think you're talking about Ozempic is maybe the brand name or something to that effect. From what I've heard so far in the news, it makes people sick sometimes, vomiting, diarrhea. So, I wonder about that. What is making this person feel like they need to go through that in order to lose weight? I know that it is a type 2 diabetes drug. I also know that there's a shortage of it in Australia because of how many people are seeking it for weight loss purposes. I know that a few months ago, Eli Lilly told its investors or somebody that they're working around the clock to keep up with demand for the drug because, of course, people with type 2 diabetes and whatever medical conditions it also treats need it too. So, and I think the expectation is that you stay on it permanently, or else the weight loss reverses. So, I don't know. I'm not sure, and I have maybe some mixed feelings about it, especially if people are doing it more, like in the news, they talk about celebrities doing it. And so I guess it's one thing if somebody really does have true medical complications related to their body weight and there's an urgent need to change their body weight. If you're in the camp that there's some connection between weight and health. When it's more for sort of body image related concerns, I wonder about that. And do we know the long-term consequences of taking a medication like that is sort of affecting how your liver, produces glucose and things like that?
Well, that was wonderful. Thank you very much, John.
You're welcome. Thank you for having me. It was my pleasure.
Sure. And again, next week we will have threat assessment with Dr. Berg and Dr. Hughes, and an email will be going out on Tuesday. Thank you very much.
Bye-bye.